Hello everyone. Today's topic of discussion is hyperthyroidism. This is the final lecture on thyroid gland and its disorders. But before proceeding further, do watch the first two parts of this lecture. You can find them on my Instagram page and YouTube channel. Let's start with the causes of thyrotoxicosis. Thyrotoxicosis means abnormal and excessive quantity of thyroid hormones in the body. And primary hyperthyroidism means the defect is in the thyroid gland itself, and hyperthyroid means overactive thyroid gland. The most common cause of primary hyperthyroidism is Graves' disease, which is an autoimmune disease, and we'll discuss it in detail in the next few slides. The second most common cause is toxic multinodular goiter. It is also called plumber's disease. In this disease, multiple nodules develop in the thyroid gland. These nodules act independently from the normal feedback mechanism and produce thyroid hormones continuously. Next is benign toxic adenoma, which is a solitary nodule that produces excessive thyroid hormones. Its treatment is to remove it surgically via subtotal thyroidectomy. Features of hyperthyroidism occurring after a viral infection along with fever, tender goiter, and difficulty in swallowing is termed as subacute thyroiditis or de Quervain's thyroiditis. It is a self-limiting disease. It doesn't require any anti-thyroid medications. Usually non-steroidals are given like ibuprofen for pain. Remember this word tender goiter because in other forms of thyroid disorders, goiter is usually non-tender. Hashimoto's thyroiditis also presents with a transient phase of hyperthyroidism initially. This is because when the autoantibodies attack the thyroid gland, they suddenly release too much thyroid hormones in the bloodstream. This phase lasts for a few weeks to months, and then the gland becomes underactive. Some women present with thyroiditis 3 to 6 months after giving birth. It has a hyperthyroid phase followed by a hypothyroid phase before complete recovery. It is also a temporary condition, so no need to give any anti-thyroid medication. We just need to monitor thyroid function test every 6 to 8 weeks. Sometimes we can give beta blockers like propranolol to control the adrenaline-related symptoms like tachycardia and anxiety. In some women, however, the gland may not recover from the hypothyroid phase, so they can develop permanent hypothyroidism. Finally, hyperthyroidism can also occur after over-treatment with levothyroxine or prolonged use of amiodarone, which is an antiarrhythmic drug. Secondary hyperthyroidism is caused by overstimulation of TSH due to a pituitary lesion, and tertiary hyperthyroidism is caused by overstimulation of TRH due to a hypothalamic lesion, but these are very rare in clinical practice. Now let's discuss Graves' disease. It is named after Dr. Robert Graves, who discovered it in 1835. It is an autoimmune disease. It is present in 2 to 3% of general population. It is more common in women, and it has a diffuse goiter as compared to toxic multinodular goiter. So now what really happens in Graves' disease? This is the thyroid gland, and these are the follicles in the thyroid gland. Now on these follicles, there are TSH receptors. Okay? Now in Graves' disease, what happens that autoantibodies are formed, which are called anti-TSH receptor antibodies. These antibodies, they mimic the TSH receptors. So in this way, they'll continuously stimulate these follicles to produce continuous and excessive amount of T4 and T3. Now this continuous production of T4 and T3 will report back to pituitary gland, and pituitary gland in return will produce less TSH, trying to compensate the high levels of T4 and T3. If you remember the normal functions of thyroid hormones, which we have already discussed in the previous lectures, then it is very easy to understand the features of thyrotoxicosis. In the central nervous system, it causes anxiety. Normal muscular growth and development is disturbed, causing muscle wasting. Bone turnover is increased, leading to osteoporosis. The patient will present with hyperthermia, that's fever and sweating. The heart rate will increase, and in severe cases, it can cause atrial fibrillation. Gastric motility is increased, so the patient will have diarrhea. Due to increase in BMR, the patient will present with weight loss. Menstrual cycle is also disturbed, leading to oligomenorrhea. When you examine the patient, you will find a diffuse goiter in Graves' disease and a nodular goiter in multinodular goiter, and you will find that the patient will have hand tremors. These are universal features of thyrotoxicosis. There are some features that are specific to Graves' disease, and they are exophthalmos and pretibial myxedema. Exophthalmos means bulging of eyeball out of the eye socket due to the inflammation and hypertrophy of the tissue behind the eyeball that forces the eyeball forward. And pretibial myxedema is a dermatological condition where there is deposits of mucin under the skin on the anterior aspect of the leg. This gives an orange, waxy and edematous appearance of the skin over the pretibial area. Diagnosis of hyperthyroidism is done by thyroid function tests, where T4 and T3 levels are higher than normal and TSH will be lower than normal. To confirm Graves' disease, we can do anti-TSH receptor antibodies. They are positive in 90% of patients with Graves' disease. In 50% of patients, you can also find anti-TPO antibodies in Graves' disease. If after clinical examination and thyroid function test, the etiology of hyperthyroidism is not confirmed, then we can do radioactive iodine uptake scan. We give a drink to the patient that contains small amounts of radioactive iodine. The radioactive iodine is only taken up by the thyroid gland in the body. So normally it distributes homogeneously throughout the thyroid gland, as you can see in this first picture. In Graves' disease, the uptake is homogeneous, but it is increased. You can clearly see the difference that in Graves' disease, the thyroid lobes are way darker than the normal ones. In toxic multinodular goiter, there is patchy uptake. You can see 1, 2, 3. These are all different nodules. And in toxic adenoma, the uptake is increased only in that particular nodule, and the area around is lighter than that. In the treatment of hyperthyroidism, we use propranolol, which is a beta blocker. It does not cure hyperthyroidism, but it is helpful in blocking the adrenaline-related symptoms like tachycardia, anxiety, and sweating. To cure hyperthyroidism, we use titration block regime. In this, we use antithyroid drugs, which are carbimazole or propylthiouracil. Carbimazole is the first-line drug because it is taken once a day, and propylthiouracil should be taken 2 to 3 times daily, so compliance is an issue with it. Carbimazole is started at a higher dose, and then it is decreased gradually once the patient is euthyroid. This treatment takes about 18 months. Carbimazole can cause agranulocytosis, which is dangerously low white blood cell count. The patient can present with fever and severe pharyngitis, but once you stop the drug, the levels of WBCs recover within a few weeks. Propylthiouracil can cause severe liver reactions, although very rare, but they can be fatal. In pregnancy, you should use propylthiouracil until 12 weeks of gestation and then change to carbimazole. The second method is block and replace regime. We give high dose of carbimazole to completely block the thyroid hormones and then replace with levothyroxine once the patient is euthyroid. This treatment also takes about 12 to 18 months. Next option is radioactive iodine. We give a drink to the patient that contains high doses of radioactive iodine. It will destroy the thyroid gland and the remission takes up to 6 months. The patient will eventually develop hypothyroidism. Radioactive iodine is contraindicated in pregnancy and thyroid eye disease. After the treatment, the patients should avoid close contact with anyone, and females should avoid pregnancy for at least 6 months. Surgery is the last option. It should only be done if there is very large goiter, or if they're pregnant women who are intolerant to medical therapy, or if they refuse radioactive iodine therapy. The patient will develop hypothyroidism after that too, so we have to treat with levothyroxine. That's it, guys. I hope you liked the video. If you want to watch more videos like this, then please follow me on my Instagram page and YouTube channel. Take care. God bless you all.